be here, and this does beat snow. So even though it's a little bit rainy this morning, not too bad. And I really want to thank Dennis, and I want to thank Jerry, and I want to thank Florence Tech, and I want to thank Leslie for inviting me. It's really a great privilege. Healthcare reform is not my favorite topic, I must tell you, because it is a little controversial, and most people don't like it, and I will give you my biases on that. But it is a very important topic, and I hope that I can give some context today in terms of how I look at it, having been in healthcare now since I was 15 years old. I've been in healthcare, I need to say it, over 40 years. And I started from the bottom up, so I have a perspective, I think, from a standpoint of a staff person working in the industry, but also a leader, and also a family member and a patient, which I think all of us are. We all deal with healthcare. Nobody is immune from it. And I think it's important that we all have some perspective on it, even if we have our own interests, which of course we all do. And I will tell you, I support reform. You know, and again, it's not politically popular today to do that. But I am a big believer in reform. Not that it's perfect today. And clearly anything we would try would not be perfect, because the complexity of healthcare is daunting. And the ability to change a system that has evolved over many, many years, really almost 50 years since Medicare was put in place, Medicaid in the mid-60s, is almost an impossible task. And we saw that it was tried many years ago under the Clinton administration. It's been discussed ad nauseum probably since the time of Medicare and Medicaid. But it's hard to change, and there are many reasons for that. But clearly the system today has all the incentives backwards. We're not paying for prevention and wellness. We are not paying for coordination of care. We are paying doctors and hospitals to do more. So we get more, and we don't necessarily get the right things done. So the system, if you want to call it a system, because it really isn't, it's not very organized, it's not very integrated, but the system basically is a financial system. It's an incentive system that, again, I think has it backwards. In addition, there is no system. You know, look at what we have in this country. If you compare it really to any other country in the world, we are less organized, less integrated. You know, our physicians basically, for the most part, are in private practice, often in single or two-person practices, completely disengaged from most of the hospitals they practice in. We don't encourage the continuum of care, and we don't encourage, frankly, some of the quality that is so needed to be really rewarded in a way that is reflected in the payment system. So, you know, to think that we don't want reform is kind of a little crazy, because we have to have reform. In addition, if you think about all the self-interests involved in healthcare, because of this incentivization of getting more, and obviously the technology, which is often wonderful that we have, but it also costs more money, and that we have extended life of older people. If there's one great success in our current environment, it's that people are living longer, because we have the drugs, we have the procedures. You know, early in my career, we didn't do knee and hip joint replacement surgery on anyone. We didn't have some of the technologies in heart care. We didn't have the medicines that we have today. So, you know, part of our problem is our own success. We have extended life of people in an amazing way. And we all are very happy about that. We all expect that. We expect things to be solved in terms of the disease process. We expect research to be done. But it's very, very costly. And we also have this problem of the pharmaceutical industry, the insurance industry, the hospital industry, the physicians, all battling it out all the time to basically keep things the way they are. Because in those self-interested groups, they care deeply about how they can continue on and basically generate the revenues and the profitability that we have today. And I will tell you, there's a big difference between the insurers and the companies that produce pharmaceuticals, devices, and the providers. Most providers in this country have a margin of between 2 and 3%. It's like the grocery stores. The margin on the device companies and the pharmaceutical companies could be upwards of 30%. So where the dollars are going is very different. And you know, the providers often get all the negative kind of impact of the cuts. because the very profitable side of healthcare pay huge political contributions. So we have a very sort of uneven playing field if you look at it and you stand back from it and look at the debate and look at the discussion about healthcare today. In addition, the size of the healthcare industry now has created its own problems. Because anything we do in this country around healthcare is going to have consequences economically. Because look at our cities today. Look at the number of people we employ. Henry Ford Health System employs 24,000 people. We're the 4th largest employer in the entire Metro Detroit area. If things come our way, we're going to, because we're very labor intensive, over 50% of our costs are labor, we're going to be cutting back. So the government's in this incredible dilemma right now. What do? Do you try to cut back on some of the provider payments and then see the consequences economically in local communities? Or do you not? I mean, we have a lot of very complex issues to consider. In addition, as I mentioned, the complexity of healthcare is overwhelming. And trying to reform it, and I'll go through a lot of detail today with you on some of the different aspects of this reform process. But to change the system is very difficult because somebody's ox is going to be gored. In fact, hopefully everyone's, because everybody needs to change in order for this whole system to change. I've commented for years that there's one thing I would change in the health system today, it's how we pay doctors. Because if we change that, we will change a lot. And I don't often, get huge applause from my physician colleagues when I say that, but I was actually on a panel with Dr. Joe Schwartz a few years ago, and I mentioned that, and then, the panel moderator said to him, do you agree with that? He kind of sat back, he said, she's right. Because, the system today, think about it, the technicians who do end up with longer periods of training and education get paid astronomically more than the primary care physicians. So nobody wants to go into primary care today. So primary care is really dying, and that's exactly what we need to better coordinate the care for our patients. So we've got that problem. In addition, most of that payment has been based on technological changes. Many years ago, I remember when we introduced the arthroscopic knee surgery. And we went from a procedure that took probably 2 hours to do, an open knee, and a lot more time from the physician, from the surgeon, to a procedure that took 15 minutes to do. All the technology was paid for by the hospital, and the doctor's fee doubled. This is a smart system we've got. So, that was the beginning, frankly, of a pattern of the specialist's income going through the roof. Of course, at the same time, our doctors end up having to pay huge amounts of debt from their medical school education. So why would a young person go into some of these primary care professions? So we have, that problem as well, which is really crazy. So, from my vantage point, reform is not an option. Because we have a tsunami of baby boomers entering the time period in their life when they're beginning to access the system tremendously. And obviously Medicare, age 65 and above, is the group of patients that the federal government pays for directly, along with Medicaid. So what's happened in this country, because of the economy and the growth in Medicaid has been astronomical in the last 5 years. Because more and more people don't have insurance, are out of work, and are accessing that system. And then we have Medicare, which is absolutely going for growth. So we have to do something. We have to change the system in order to move ahead. Now, it will be a journey from my vantage point, because nothing this large and complicated is going to be solved in one piece of legislation. We are going to learn as we go. There's a lot of change that has to happen in the delivery system of care, and I'll talk a little bit about that as well. But I think we are starting that journey. So the good news is, whatever your political persuasion is, we have started that journey. And I have not heard really anyone else come up with a better strategy yet. I mean, if you listen to the politicians, they want to get rid of Obamacare, but have you heard anyone say what should be done? It's because it's so hard. It's very hard to do. It's actually a miracle that that legislation got through. Just to give you, again, some perspective on where I'm coming from. I've been in healthcare, as I said, 40 years. I started as a volunteer when I was 15 years old. I worked on the front line as a unit assistant, a nurse aide. Began my administrative career in Akron, Ohio, where I grew up. Same hospital I was a volunteer in when I was 15. Ended up running that hospital, 650-bed hospital. Started doing that at the age of 28. So I've had really deep experience working in phenomenal hospitals. I worked in the Duke Medical Center in Durham, North Carolina. I worked at Memorial Sloan Kettering. I worked at Henry Ford. I worked at a very large Catholic system across the country called Catholic Health Initiatives. I spent time in Columbus, Ohio, and Akron in very important, integrated, large health systems. So I have a perspective, I think, that is rather unique in the industry. And I will tell you that there is a model out there that I think we should all be trying to emulate. And while it sounds very self-serving for me to say it, my perspective, I think, allows me to say it. The Henry Ford Health System model, which some of you may or may not be familiar with, is a very unique model in this country. While we are somewhat like the Cleveland Clinic and Mayo Clinic because we have a salaried medical group, we are also like Geisinger and Intermountain Healthcare because we have a health plan. And the combination of those two make us a very unusual system because having doctors work for us in salaried positions with the incentive to do the right thing, because they have very little at risk compensation. So in essence, we're paying them to do the right thing for their patients. We're also paying them to innovate, and we're paying them to be part of our academic mission, teaching and research. So we select them. You know, they don't just come to the door, knock on the door, and say, I want to be an admitting physician here. And of course, most hospitals will take almost anyone because they need the admissions. We select our doctors. That is a fundamental difference and something, you know, when I came to Henry Ford, I thought I'd died and gone to heaven because it was a fabulous way to deliver care. In addition, the health plan gives us a front door to all of you who are business people. We work with major employers and small employers and individuals in the marketplace, and we know the challenges you face from a cost and a quality perspective. So it puts it right in front of us. And our physicians, frankly, help us. I mean, they partner with our health plan on a lot of innovation around chronic disease management, e-prescribing, ways that we bring technology in and are able to scale it very quickly. So it really is a tremendous model. We also are not hospital-centric. We are care-centric. So we have hospitals, but we also have a huge ambulatory network, which allows lower-cost care to be delivered closer to home. Most patients don't go to the hospital that much. Most patients come for outpatient services and have them well organized, conveniently located across the market in Southeast Michigan, I think is a tremendous way to deliver care. And we also have what's called the community care services. And we offer literally from soup to nuts in healthcare. So not only do we provide extensive primary care and wellness services, but we also provide hospice services, home care, dialysis across not only Michigan, but also in Ohio and other markets. We provide eye care services, our Henry Ford Optimize. We provide medical products online and also in sites, helping people figure out when that patient comes home, how do you adapt your home to make sure that you can deliver the care that is often very essential to their recovery. And we're very focused on two elements that I think are so critical. One is innovation. We're constantly looking for better ways to deliver care. And the other is integration. Because how many of you, you've all been patients, you've all dealt with the health system. Real easy to navigate, isn't it? No. You know, my mother was a patient for 3 years, dialysis treatment, before she passed away, cancer treatment. She had 8 different specialists. Thank God she had a quarterback, an internal medicine physician who helped navigate her care. And she had me, you know, constantly working to figure out all the transitions to make sure she had what she needed. But a lot of people don't have that. And it is really challenging to work in an environment where you don't have all the services that can be well orchestrated and put together. So I think that, again, I wanted to give you my biases. I wanted to share my perspective before I talk about reform in a little bit more detail. I will be open to your questions as we go through this if there's something you don't understand or something you want to ask more questions about. And at the end, of course, I hope we have plenty of time for some dialogue. I will also tell you that I am not the expert on this. While I've served on the American Hospital Association board, I certainly weigh in a lot of forums. I was chair of the Michigan Hospital Association board. We have people in our organization, frankly, who know all of the technical details, the people on the payment reimbursement side as well as our government affairs people. And they helped prepare me today, but I can certainly give you other resources if you have specific questions that I cannot answer. I'd be happy to do that. So, you know, this notion of, you know, where are we? When I was walking in today, I met a gentleman who is in the behavioral health area and, you know, talked about all the uncertainty. Well, we live in that world. I mean, frankly, it is an incredibly uncertain time. You know, we thought we had reform, and then we start talking about repealing reform. And we also are in the context of an enormous economic dilemma that we face in this country, and that is what to do in this economic climate about our deficit and our deficit spending. So while we thought, when reform was passed, that the providers had anteed up, if you will, for some very substantial reductions in payment, now we're back at it again. Some of the things that are being proposed, frankly, right now, for us, are just draconian. They would put us out of business. The amount of reductions that are on the table as part of the deficit plan for urban, academic, safety net organizations, which we are in Detroit, literally would probably make it impossible to do business because we have to have that 1.5% margin just to be able to continue to support our capital needs. So it's a very daunting time for all of us on the provider side as well as on the business side, trying to figure out what is this future. So these are the things I'm going to talk about today, sort of the deficit debate in health reform, how it fits together, the repeal efforts, and then ultimately what that law looks like, and some of the dimensions that I think all of us probably would agree are positive and those that are much more controversial. So we know that today we live in a world as a provider of health care where government relations is at the centerpiece of what we have to be paying attention to every minute. Because half of our payment on the provider side comes from the government, whether it's state government or it's federal government. And as you can tell, right now, we're in the midst of an election year, so we also have all of the sort of banter and discussion that frankly makes it more confusing to know what to believe as opposed to really getting at the fundamentals. So I hope today maybe we can clarify some points. As you can see, this is kind of the world we're in right now. The question is, do you spend to really make the economy move forward, or do you cut? And I think the question right now is, you know, which is right? Is there a combination of things that make sense? And, you know, how do you get to the point of more stability from a financial standpoint nationally? And they are two different discussions. The deficit spending, you know, our government relations person, Darlene Burgess, described it as maxing out on credit cards. I mean, in essence, we are just chronically overspending. We're spending more than we take in, so we are constantly in a deficit situation. And the federal deficit, which is our debt, basically is like a 30-year mortgage. So in essence, we are spending, it's about 8% of GDP, which is a little bit larger than other countries. Reminds me of the city of Detroit. If you look at what's happening here, we have $14 billion in debt, but basically we're getting more in debt to cover the deficit spending that we have in terms of revenues versus expenses of the city. Very similar on the federal level. That's exactly what's going on. And the problem we have is that while we definitely need to address it, the question is which is going to tip? What's going to make it worse? What's going to make it better at a time when the economy is so weak? In 2011, the overspending was projected, and I imagine it came in close to this at $1.5 trillion. You can see that differential between the budget and revenues. The deficit, we now have accumulated debt of $14 trillion, and a lot of it is related to this unfunded expenses and this disparity between revenues and expenses. We've got hit with a ton of things over the last few years. The Wall Street bailout, having to put a stimulus package in place, 2 wars that frankly were not even included in budget kinds of numbers for years, and you know, and the longest wars in history the extension of the Bush tax package, which was supposed to end and would have brought additional revenues in, but it was extended because basically from a political standpoint, people did not want to do that. So again, you can see the challenge. And as I mentioned, healthcare cost growth definitely contributes. We've got this challenge of state budget problems on the Medicaid side, so the federal government has definitely helped the states with Medicaid payments. The state of Michigan, a huge portion is federal match coming in higher than normal because of the way it's been structured in the state. And frankly, these costs really threaten the viability of the program because, as we know, the Medicare Trust Fund is going to run out of money in the not too distant future. And we are trying to figure out, what we do to bend that cost curve down. And I think you can see with this chart the challenge, because as we get into those out years, when the continued aging of our population, the percentage difference between growth in GDP and the growth in healthcare is going to be just huge, and has been, frankly, for many years. The thing that I think many people don't understand is that when health reform was put in place, you heard numbers like 2014 is when the expansion would take place for access. The reason for that is that what they put in place were significant payment reductions on the provider side, on the pharma side, basically to help fund the plan. So from our vantage point, as a provider, we're getting cut, no improvements in access. Our uncompensated care and reported health system continues to grow at a rate of about 10% growth a year. We now have over $200 million cost-based payment that basically we provide free to people in our community because of the tough economics here. And there also is a lot of concern over this geographic variation that exists across the country. So those people in Minnesota, as an example, that tend to get lower payments for a lot of legitimate reasons. They don't have the poverty, they don't have some of the health status issues that certainly we face in our state. They're trying to level the playing field, which again would be disastrous to those states that have urban areas, higher poverty, because what happens to Medicare patients when they get older and they are poor to begin with is their health status is so poor that the costs are even higher. And those are costs that are borne certainly in the payment structure by the providers who provide care. Let me just show you visually what that looks like. You can see in major urban markets and where there are a lot of Medicare patients, basically the costs are higher. And in those markets that, out west and in states, for example, Utah has the best health status in the country, their numbers are lower. The thought of, if you look at the difference between 5,000 and 16,000, to try to level that out, those who have been relying on that payment, their cost structures are built that way, would face enormous challenges. And those that, frankly, get more money, you kind of wonder why, because many of those same organizations are doing just fine today. Their margins are healthy. There's really no reason other than perhaps greed to want more payment. And so we've got some very significant issues as we try to navigate these waters. Basically, both the executive branch and the Congress have agreed to address deficit spending and long-term debt, but they have very different paths to doing it. And this next chart, I think, is, well, this is actually a nice example of how it looks. If Medicare is sort of the body and tax cuts are the apple above it, you can see the Obama plan wants to tax the rich. The GOP basically wants to tax Medicare and reduce the payments. And you can see just in the Ryan and Obama plan, just the difference that takes. Ryan wants to basically reduce taxes. Obama feels that the wealthy should be taxed. Expenditures should be reduced across the board, but obviously Obama is much more moderate in those reductions than Ryan is suggesting. So again, this is an example. You have to stay current every week to find out exactly what's going on, but it gives you a pretty good picture of kind of the dilemma we're facing. I think the public supports action on both. I think we are all, as citizens of this country, quite concerned about the economy, the lack of job growth, the loss of autonomy to foreign investors, and frankly, we're concerned about just the state of our current situation with deficit spending and a huge amount of debt. The first casualty of this were earmarks, and I think, basically this has been an interesting debate because for years both parties benefited from the concept of earmarks, things they could bring to the local environment, whether it was a bridge or it was a new building. Sometimes, things that frankly nobody could see the reasons for, but some of it was very legitimate and purposeful. But again, I think you can see that basically everybody kind of decided that wasn't the way to go. This is a little bit dated, but the issue here in terms of the debt limit is that how do you basically handle it? And one of the things that are being considered is tying annual spending to the growth of GDP, so that again you can narrow that gap and not have additional deficit spending over time. Having triggers that require automatic reductions or new taxes, again, to keep the economy in balance. In Michigan, we have to have a balanced budget, so we're in a different mode here, frankly, than the government is. And then, the cuts to major programs, as I mentioned, are a huge threat to providers, and cuts equal to the hike in the debt limit, again, trying to balance that out and make sure that as we have improvements, that we see cuts that basically try to target that. And then budget targets for 5 to 10 years, again, to look out with more of a strategic view, because as we know, these issues have been anticipated for decades. But the ability for our politicians, frankly, to do really strategic planning and to make decisions today that are long-term in their impact is quite limited, because everybody is looking for that next vote, and they quite honestly don't really look at the world that way. I like this. So we know we're in a world right now where we have a lot of people trying to figure out ways to kill Obamacare, and specifically the Republican budget this past year included repeal, and they do it in a number of ways. One is to basically get Medicaid, put in place Medicaid block grants, which would limit the amount of dollars coming into the states. And of course, the governors are very concerned about that because they're struggling with their state budgets and growth in Medicaid. Convert Medicare to premium support or voucher program, basically to push more of the costs back on patients as well as on providers. And then also to, in essence, repeal the entire law. But what's interesting, if you look at the budget situation in the next few years, if Obamacare were actually repealed, costs would go up, because as I said, in the initial years, there's a lot of cost reduction built into the plan in order to fund the increase in access. So they're kind of in a catch-22 right now. If they in fact did that, they'd have to find other ways of reducing costs as opposed to what's included in the current legislation. A lot of core challenges focus on the individual mandate, whether that's constitutional. The challenge we have in this country is that unless everybody plays, the whole thing is like a house of cards, frankly, it would fall apart. Because, what would happen is then we'd have an imbalance around how everyone is really supporting the increase in access to care. And I think the whole thing would have to be rethought if, in fact, we see the individual mandate voted down by the Supreme Court. And that will happen in the next few months. We will know by June whether, in fact, the individual mandate is viewed as constitutional or not. There's debate about whether it would crash the whole thing, but from most people's perspective, it would create a huge problem as we try to move forward with the plan. And there are other ways that basically the Congress could dismantle the health reform package, the packet as we call it. One is that they would basically defund the budget for oversight of small business compliance. So in essence, the notion that everybody's in and everybody's playing needs some level of enforcement, so they could make that sort of moot, and then the whole thing again could not work very effectively. The federal grants for health exchanges. It was interesting. I had an opportunity recently to talk to Governor Snyder about his thinking about exchanges. He thinks they should go on whether or not we have reform, because frankly, many people are buying health care on an individual basis. The notion of exchanges actually allows for a better competitive environment and much better information for individuals trying to make those choices. So having an on, sort of like saying, would you like to book your air flight kind of without the internet, without looking at choices, without looking at costs? I mean, today it's very transparent for most of the things we buy, but not insurance. It's not transparent. And so the opportunity to create an exchange actually is a very positive thing, I think, from a purchaser standpoint. And I was pleased to hear Governor Snyder's comments on that, because I think he's right on point. In addition, there's opportunity to defund what's called the Center for Medicare and Medicaid Innovation, which is not a huge amount of money, but it's a very important aspect of the health reform legislation. This is being put into place to help really drive some of the innovation in the healthcare delivery system that I described that Henry Ford has. There's a great interest in creating more integrated systems and creating incentives for doctors, frankly, to work for hospitals, which we're seeing a lot more of today. And I think also the opportunity to create better continuum of care and integration through bundling payments, so that if you're paid for a particular chronic disease, you're paid for everything. You're paid for home care, you're paid for the office visits, you're paid for inpatient. So there's an incentive for those components to work together in a very different way than they do today. And the other thing is to delay the Medicaid expansion. Now, again, sort of my bias here, having served here in Detroit for 13 years with a very high level of poverty and a lot of people that don't have access to care. The Medicaid expansion, frankly, from a country standpoint, if you look at every other developed country in the world, they provide for their citizens. So I think the opportunity to reduce substantially the uninsured in this country and provide basic medical care makes sense, and I think delaying this would just create more problems, because I think, again, the cost of care is encouraging many small employers to not provide health care benefits. So people are out there, even working people are out there without coverage. And, for any of us who have been sick, the whole notion that we could, in fact, it'll go away. But the notion that you could be sick and not have access is probably one of the most frightening things you can imagine. And, I think even those of us who might be very conservative fiscally, from a humanity standpoint, know that people need to have health care. And so I think, again, the opportunity for us to move ahead with expansion is absolutely critical. So finally, let's talk a little bit about what's in this bill. And, and again, complexity is enormous here. There are very few people that really understand this bill from the beginning to end. It's, thousands of pages of legislation. There's a lot to it. But basically, what the reform focused on was the concept of health insurance coverage for all, and addressed the ability to pay for insurance. So it basically looked at different economic segments. How people receive care today. Who gets employer-sponsored care? Who doesn't? What is their ability to pay for it? We look at that all the time at Henry Ford, because one of my greatest fears is that, again, because of just the cost of coverage that we all pay, the premium piece that we pay, the co-pays and deductibles, that some of our lower income employees at Henry Ford will not be basically using the benefits that they have access to. And, that we have uninsured people within our own organization. So we actually go out and we look at that, so we understand what's going on, how many of those individuals are using our benefit, and then what can we do to have a sliding scale so that they, in fact, will pay less if they have less of an ability to pay. The same thing is going on in the health reform package, trying to think through how can we make sure that people have access to care. Now, one of the things that I think many people in Michigan don't understand is that today, our current Medicaid program is extremely limited. Historically, Michigan was a state with a very high level of uninsured people because of very good benefits, the auto industry. That's not so true today. In addition, if you look at the coverage, it is actually at the 66th percentile of the federal poverty level. If you look at Minnesota, they're at the 250th percentile of the federal poverty level. This Medicaid program in the state of Michigan basically covers women and children. If you're an adult male, you don't have a chance. And frankly, at that level, $11,400 income for a family of 4 is what that federal poverty level is. So in fact, you don't get any coverage. If you make $15,000 a year and you have a family of 4, you're not eligible for Medicaid. So while people think that Medicaid is there for everyone, it really isn't. And the other problem in our state is that, look at the growth in poverty. And, these are people who want to work. This is not people that are entrenched in trying to game whatever system we have. These are individuals who want to work, can't get jobs, don't have the wherewithal to move to a place where they might get a job, and basically, don't have access to care. So again, I think it's important to understand the sort of demand side for this and the issues that we face even close to home. Health reform also addressed insurance-based key determinants of affordability. So it restructures insurance risk and disallows pre-existing conditions so that people, in fact, who are ill can receive care. And again, this is a tough issue when you think about it, because if you have a cancer diagnosis when you're young, your ability to be insured could be affected for the rest of your life. And children who were diagnosed with cancer. So, this is just not, I think, who we are, as a society. It's not really what we want to see happen. And we also want the insurance rules to help individual and small businesses to be more like large businesses. Because obviously large businesses have a lot of scale and clout and ability to manage risk. And I think the same thing needs to be in place for individuals and small businesses. So the idea of creating these health exchanges is to restructure the pool and create larger pools to share that risk across the entire spectrum. It also standardizes rules to increase dollars spent on health care. For example, the insurers sometimes have a medical loss ratio, which means out of their total pool of funds, sometimes only 75% of their revenues are spent on care, which means they have 25% for administrative costs, for profit. Pretty extreme. Again, as I said before, that's not true of most providers. So when you look at the concept of requiring that their medical loss ratios, the amount of money they're spending on care, go up to 80 to 85%, that's basically to address that issue. It installs the individual mandate again so that there's no free riders out there, everybody's contributing, and the Medicaid expansion and standardized eligibility state to state, so it makes it certainly more consistent across our entire country and how we're delivering care to people. Other issues, again, some of these cost factors that I mentioned earlier are not really addressed, except for Medicare. And within Medicare, it's been a journey. For example, in cardiac care, there's been a very consistent effort to reduce some of the payments for heart care because they were, frankly, quite out of line. And the profit center that heart used to be for many hospitals and physicians is being mitigated now. In addition, the things that I talked about between primary care specialists have been modestly addressed, but clearly are not going to change, I think, the incentives of young people to go into specialties as opposed to primary care. Cost factors related to new technology are not solved. Many of us would say we hope they're not solved because we do like the fact that new drugs continue to address important challenges that we face as humans. And we also would like to see probably drug pricing and, again, the profitability of the pharma industry. But, there's always a push-pull there because certainly the work that they do and many of the advances that have been made have been in that part of the industry. The aging of the population, basically the dilemma that Congress has is while they perhaps would like to change the eligibility requirements since we are living longer, raise it to age 70, become eligible for Medicare, or to push more of the cost back on the individual, particularly those who have the wherewithal economically to pay for it. Never is popular in terms of the electorate, so those things, frankly, don't usually advance very far. Longer-term improvements basically will come with more health promotion, disease prevention payments, but in the short run, those add to the cost because those are long-term strategies. When we pay today to help people manage their diabetes better, when we pay for preventive services, hopefully to avoid diabetes, you don't see the results right away. And again, because we don't have this long-term thinking, we end up sort of back to square one, and it's an increase in cost as opposed to something that people can find resources for. But it does actually support this trend toward delivery system integration, because there are things, particularly in the Center for Innovation, that are trying to create demonstration projects. You may have heard about the fact that U of M, Genesis, and DMC are participating in what's called the Pioneer ACO, Accountable Care Organization. They are basically trying to replicate what we already have in Ford, and that is the ability to integrate the doctors in the hospital, and the ability to really manage to a cost like we do because we own a health plan, and have a capitated model for our physician payment. So these are the things that I think are very important. And it's exciting that Michigan hospitals are going to be right there participating in that process. So why are people upset? There are a lot of reasons. I think one of the things that is probably front and center is number 4, because the insurers out there are anticipating what's coming and are increasing rates because they can. And it frankly doesn't make sense if you look at the cost structure today. Over the last 2 years, it's actually been moderated substantially. If you look at actual costs, both Medicare, Medicaid, and commercial. But insurers will know that they have cycles, and they try to get the money when they can, and then they basically have to kind of take it on the chin at some points in that cycle of insurance payments. So that's a big reason. I think particularly small employers are very angry and upset. There's political opportunism going on. Certainly, if people want to get rid of President Obama, this is an easy target. And it results in a lot of people, again, because of the complexity and uncertainty, people are afraid about any changes in health care if they have health care coverage today. And I think that's a challenge. And then just the complexity of the bill and the certainty that people look for to try to plan from a business perspective. Again, the philosophy of reform is coverage and insurance. Most people, frankly, are not affected, particularly if you're in a large group, a larger employer. They're affected because of just the cost pressures coming. I mean, obviously all insurance is being changed today, more co-based deductible and sharing of costs by employees. But, there really is sort of a do not disturb philosophy, trying to go after each of the segments, trying to figure out a way that they come together with some sense of logic. And it did reject what some people would like to see, and that's an all-payer kind of model, where we basically have a national health plan. And because of the distrust of government today and a lot of other issues, I don't think that's in the cards at all. And the fact that it does encourage competition among not only providers but also insurers and other segments of the market. Just to get a feel for the total population and kind of where this stands, in the country today, out of a 300 million person population, about 100 million are covered by Medicare and Medicaid. But again, if you look at costs, particularly in the Medicare population, they're much, much higher than the average working population. 150 million people have group or individual coverage, and 45 million are uninsured, and 14 million basically are out there as individuals. Many of this is truly charity care, individuals who have no ability to pay. So that top segment, the 45 and the 14 million, are really where much of this legislation is targeted in terms of improved access. The financing, as I mentioned already, comes from health providers, from the tax on insurers, and basically payroll tax, and it is $1 trillion cost over 10 years per year, or in total. I think I've covered this, so we'll move on. Again, on the delivery system side, Darlene describes it as an osmosis philosophy, meaning that if we do enough kind of pilots and demonstrations, we create more transparency of price, and that we also use the Medicare Payment Advisory Board to basically weigh in, that we will drive innovation on the delivery side. I think much of that is true. We're already seeing a lot of change taking place on the delivery system. Many more physicians are being hired by hospitals today. In fact, out of the last resident class that graduated this past year, 50% of the graduates were hired by hospitals. That is a remarkable change in a very short period of time. And I think the other very important aspect is that there's a phase down of disproportionate share monies, meaning that those hospitals like Henry Ford that qualify for this payment because we take care of so many uninsured people, as we get improved access, that should phase out. The tricky part is by an institutional, at the local level, how quickly are people moving into that Medicaid access? Is everyone signing up? Is everyone truly receiving access? And how do we work to make sure that that happens so that, again, these safety net hospitals are able to keep their balance? Other research going on, again, is that there's sort of this new Outcomes Instituted Trust Fund. There are depression care centers trying to be developed to move in this direction. There's a new Deputy National Center on Minority Health. I'm not sure what the Cures Acceleration Network is, but I'm sure if you Google that, you probably find out. I haven't heard much about that yet. But again, there's interest in this bill in trying to encourage new organizational models, new innovation. In terms of the workforce in the future, basically, and I'm talking about the healthcare workforce now, there are no reductions in medical education built into this legislation, which was a huge sigh of relief for those of us who provide that training for future doctors and nurses. But in the current deficit discussion, there is enormous focus on reductions in medical education. So one of the big dilemmas for our state is we're the 6th highest medical education state in the country. We train more doctors in Michigan than most states. And as a result of that, we also have a higher quality of care because when you're training, you're learning, and you're innovating, and so we benefit from that in the state, I think, by being a provider of trained physicians. We also supply our own, which is very important for the future. But if we get hit with medical education cuts, Michigan is going to have a disproportionate impact in terms of those cuts on some of our finest hospitals in the state of Michigan. So that's a concern. There's limited investment in the legislation in physician training. There is a new workforce commission that's being put in place. And there are some bonuses for primary care, but they're fairly modest. And again, I don't think they'll move people out of the mode of thinking about specialty training as the career path for young physicians today. And information technology. This is a very exciting area. It's great to hear that Lawrence Tech has a new program in health information technology, because I think all of us who have been in the healthcare space for a long time believe that this is exactly what needs to be done. Incentives built in, much like they were in the 50s, actually, for hospitals to be built in this country through the Hill-Burton legislation at that time. Now there's incentives for hospitals to convert to a truly electronic medical record, to do it, hopefully, again, with very high qualified vendors. Henry Ford, just to give you an idea, we are investing over $300 million over the next 5 years in a complete integrated solution across all sites of care within our health system. And we've been in that business for a long time. We actually were a pioneer of electronic medical records back into 25 years ago. But as we've added new hospitals and built new things, we don't have the same platform across our system because of the old technology that we have in place. So we need to adopt this new technology and move forward with it. We think it's a great thing. We're very excited about it, but it does require, again, a national perspective, not only on payment, but also on privacy, protecting patient information, standardization, and having, again, a platform that is very expensive to build in place for each hospital and each physician. So it will take a while, but there are reasons why it's not quite as simple as some other things that are out there. Again, the structure basically preserves the state and federal roles. The fact that we really don't have a unified health system, whether we're talking about Medicare and Medicaid, or we're talking about commercial payment, or the provider system in this country. So we're still keeping in place some state control, as well as some federal government control. The challenges are these Medicaid programs are very different state to state. And frankly, the states that have richer programs sometimes are punished in some ways from those who don't. And there's an uneven aspect of how we're trying to deliver care across the country. The impact, again, on Michigan is significant. We anticipate that Medicaid in this state will grow by about 500,000 lives with the new standards and moving to 130% of federal poverty level, as well as opening access to people that don't have coverage today. In Southeast Michigan, again, because of our size here, it's even a very high number. And we expect that initially there'll be more ER visits because people will not have primary care physicians to go to. Just because this Medicaid access is expanded doesn't mean that there are going to be providers sitting there ready to basically handle this new capacity and new demand for their services. So that's a critical element. And the new revenues for Medicaid, basically we're looking at $2 billion per year for Michigan, and the state picks up about 10% of that cost in 2020. So again, the federal government is helping the states put this in place because the mandate for expansion of Medicaid, states couldn't absorb that, so the federal government really is providing support for that. And looking ahead quickly, as I said, the expansion to 133% of the federal poverty level, as you can see, that gets to, frankly, a more reasonable level of $20,000 in annual income for a family of 4. Health exchange is open. There are tax credits for families that are in the 100 to 400% of federal poverty to really help them with the acquisition of an insurance plan that they have to pay, obviously, a portion of. Tax credits for businesses that have small businesses. Individual mandate would be enforced. And again, as I mentioned, there's some question about that, how that enforcement will take place. And business penalties that allow purchase coverage through the exchange. So basically, there would be a penalty if you opt out, and each business is going to have to decide, which is worse, basically helping through the exchange to provide coverage or not. And large employers would benefit from charity care subsidy phase out. So there are some employers that are paying the cost today of the charity care that is built into the system. So you hope that there will be, again, a leveling and an ability for providers not to pass on those costs in a disproportionate way to the employers in the community. Again, as I mentioned, this is a journey. There are a lot of technical amendments that will be likely. Whenever legislation is passed, actually building the regulation and building the procedures that are required to put it in place are substantial. And I think there are a lot of issues as we move forward that we will try to deal with. And we always like little cartoons. Again, I talked about the growing Medicare burden, and this basically shows that top line really is the current path we're on, which is 2% above GDP through time. And I love this one. It's a strategic view. So thank you so much. I look forward to your questions, and I know it's a lot to absorb, but I hope it's helpful in some aspects of it.
Thank you very much. And now we'll handle questions from the audience.
And I'll talk about anything else too if you're sick of it.
I do have one to start with, though, that you were missing. I don't think with what all went into the national recognition from the law report that before health care received back in the country.
Oh, I'd be delighted to talk about that. In fact, it's so rare that when I stand up in front of any group, I don't talk about that first. I don't know what happened this morning. Maybe it's the rain. We have, for those of you who are not familiar with the Baldrige process, it basically is something that was developed back in the mid-'80s to encourage quality and innovation in business in this country. And it was developed by the Department of Commerce. It was to honor Malcolm Baldrige, who was a previous Secretary of Commerce. And there are only about 100 companies that have ever won this award. And it was introduced in healthcare in the mid to late 90s. And there are only 15 hospitals or health systems that have ever won the award. And the reason very few people win it is it's an incredibly difficult discipline that you have to demonstrate across everything that goes on in your organization. And there are 7 categories within the Baldrige framework that we have been working on literally for 7 years. We applied 5 times. We had our first site visit this year in October, and we were delighted and amazed, frankly, that we won because we are the largest, most complicated health system ever to win it. And I decided early on in the process that we were going to do it as a system because I didn't really care when we started whether we ever won. I wanted to use the framework to make us a better organization. organization. And it is in areas like strategic planning and leadership and your use of data, your results, your focus on the customer. And we have used the Baldrige framework to really advance everything we do and to make it absolutely systemic across every element of the organization. And that's a hard thing to do. We have 24,000 employees. And, we're in over 200 sites of care. But we really started to see how it helped us. And that was the motivation. And we stayed with it, and we're very pleased, obviously, to have the opportunity now to be kind of a role model organization. One of the things that when you win the Baldrige Award, you have a lot to do. Not only do you get to go to Washington to receive the award, hopefully from President Obama, but you also have to go out and talk about how you got there and what you do. And you have sharing days and presentations. And I've been invited to, I can't tell you how many places across the country to come talk about it. So it's fun. And I think, we have to even get better, I will tell you. Because despite the fact we won, we are far from perfect. And, in fact, we talk about the fact we're an imperfect organization that is striving for perfection. And we're never satisfied, and we constantly work to improve. But, with the spotlight on us now, we're going to have to improve even faster. So we hope over the next year we see even more dramatic improvement in some of the basic result areas that we've
Well, congratulations again.
Thank you.
There's a question, Dennis, you have a...
Hi, my name is Deborah Johnson. I too have been in the healthcare field for 40 years this year. And it's not
Congratulations.
It's 40.
No, it is. That's wonderful.
I really admire your stance on healthcare reform because I don't hear that stance very often, and it definitely speaks to what I see in my life. I own a company that's made of nurses who specialize in community case management. And this is a field that I think can assist this entire reform, in fact is at this point, in a very small way but very important way. I hear a lot of information regarding healthcare reform talking about physicians and hospitals and exchanges, but I think we have a very powerful way to intercede, at least where we are right now, we're moving to, and that is using nurses with great experience in the politics of medicine.
I agree with you.
And partnering them in the community, where most of our illnesses, mistakes, dangerous situations occur, with our established, I can see a partnership with our established care organization that hasn't really been used. Medicare does it with home care, but only for 60 days, and that's not where you have most of the problem.
You're right.
It's a year or two into chronic illness.
Absolutely.
So that's really one of my goals, is to take a look and see how we can use those experienced nurses who have been trained in the community resources and integrate them into this healthcare reform.
I think you're on the right path, and I applaud you for creating a business that does that, because frankly, we need more guides. We need facilitators. We need people to help people navigate the system, and knowledgeable people. And, a very good friend of mine who served as the chief nursing officer in Akron when I was there is in retirement now and has created her own business, basically helping older citizens navigate healthcare and helping families deal with the very daunting issues, especially for those of us who have aging parents who are out of town, and we can't necessarily be there to help them. It is very scary. So I think those businesses, frankly, will be businesses that many of us will seek out in addition to government paying. We will need those services in order to handle, I think, what we see lying ahead. That's great. Thank you.
Question here.
Yes.
Hi, my name is Ann Conkey, and I am the program director for the Health IT Management program here. And I'm now full-time in academia here at Lawrence Tech on the faculty of the College of Management. But prior to coming to Lawrence Tech on the faculty, I worked in IT for 25 years. I designed software, I implemented project manager, and I was a vice president of IT running staff. And so my research interest is the user acceptance of technology. And even though every hospital now is investing quite a bit of money in the technology, I'm very interested in the patient's acceptance of the telemedicine, as well as the doctors and all the clinicians they have to use. Because in 2014, when the goal of the stimulus bill is to get an electronic medical record for every U.S. citizen, that is actually forcing the whole nation to electronically implement these systems. My question is how is your organization doing regarding the doctors and all of the clinicians that implementing those?
Oh, it's a great question, and frankly, it's what keeps me up at night when I think about our installation of Epic, which is this enormous system that we're putting in place. Couple thoughts. You know, again, we have 25 years of experience, so we have seen our patients very accepting of the electronic record, especially when they are brought in the exam room and they can look at their results, whether it's their radiology films or their laboratory results, and they can see, in our case, where if you go to any part of our system, all of that information comes together. So from a patient perspective, they don't have to reiterate, well, I saw this doctor that day, you know, I did this, and because a lot of times today, the physician that you're in front of doesn't know all the other things that you might be doing with other specialists or other organizations. So the ability to bring that together for a patient, I think, is huge. I mean, today, you know, you often see patients carrying around their radiology films and carrying around this and they won't have to do that, you know, if we're successful. So, and people today are very savvy. You know, we have this myth that older citizens can't navigate the web or, you know, use technology. That is so wrong. We find that that's not true. We also introduced e-visits, and many of our physicians encourage their patients to communicate with them by email. So we have really seen a high adoption rate, and patients very willing to do that. The thing that's starting to come out, though, in the literature is that providers, nurses, and doctors can get so consumed by the technology they forget about the patient. And there's been some articles recently in national press that talk about that. Because, you know, if you go into your exam room, you know, and obviously you put on that beautiful patient gown, and you're, you know, very vulnerable. If your doctor is just staring at the computer, that's not really great. So one of the things that we're really working on, and I think our educational institutions need to work on as well, is how do you integrate technology effectively and not lose the humanness, you know, the relationship with your patient, the communication, the listening that you need to do. Because, you know, we all have the information. As patients, we know a lot more than our doctors. And, you know, I'll tell you a funny story, because my dad is 89, and I manage his health care very well. That's why he's 89. But, you know, one day I took him to the doctor, and I made the mistake of not going in when he was talking to the doctor. So he comes out, you know, and he told me about these problems he had. He said, "Dad, did you talk to the doctor?" He said, "No, I wanted to see if he could figure it out on his own." I said, "Dad, it's not how it works. You know, you're the most important element of your care. You got to tell them." So, you know, it is, but I think we've got to find that wonderful path. I will also say that in today's world, you know, the only doctors we worry about anymore, because technology has become so integrated in our lives, are those who are resistant. You know, sometimes I'm not going to change, and that's a smaller and smaller number. You know, the younger physicians just can't wait. I mean, it's like, what are you doing? Don't you have this? And so I think over the next 10 years, we're going to see a complete adoption. And as long as we don't forget about our patients, I think we'll be okay. Yes.
Good morning. My name is George Wynn with the Children's Center. Can you speak a little bit about the impact of healthcare reform on behavioral health?
You know, I wish I had a really good answer, because my belief is that well before reform, our country does not appreciate the value of behavioral health services, does not reward them very well. You know, some of our benefit packages have not been built right in order to really incentivize the right care. At Henry Ford, we are the largest provider of behavioral health services in the Midwest today. We are one of the few organizations that have not, frankly, abandoned inpatient psychiatric care, addiction medicine, a lot of the outpatient services. So we believe strongly that behavioral health has to be integrated into the mainstream of healthcare. We find that our chronic disease patients, as an example, probably a third to a half of them are depressed. So we're talking about the fact that, you know, we need to look at the whole person. Behavioral health shouldn't be moved over here. We need to integrate the payment structures. We need to integrate the care much more effectively. We need to integrate with our community partners, because it's not all done in the traditional health system. A lot of it is done in the community. But frankly, there isn't much in the bill that really addresses that. I think the only way that we're going to do it is as providers working together to figure out how to do this better and more economically and more effectively. And work with insurers and employers to constantly remind people of how important the behavioral health services are to absenteeism, to productivity, to economic health of our organization. So I think it's how we look at it. It's going to be very important.
Next question is here. Good morning. I'm Kirk Goddard with JVS. The state of Michigan is one of 15 states that has an agreement with the Center for Medicare and Medicaid to create a pilot program for the dual eligibles, people with Medicare and Medicaid. That plan is supposed to come out sometime probably in late February. My question for you is, what are the two things that you're most concerned that they might come up with? What are the two things that you hope they come up with? And as a health insurance, is your system interested in possibly being one of the players if they do come up with a plan that someone takes over for everyone in the state? Would Henry Ford's system be interested in being that company that runs it?
Well, the answer is we're very interested, and we have been involved in working with Steve Fenton for the Medicaid program and Olga Dazzo, head of community health, on this. And the reason, I'll tell you why. We have a huge number of dual eligibles, first of all, that we take care of. And secondly, we have a program called PACE, which is a program for the acute care for the elderly, which is basically a capitation program. It's a model that was built out in San Francisco, primarily for the Asian population, where you receive a capitated payment. And these patients are typically Medicaid, Medicare eligible. And the goal of this program is to reduce costs, manage that expense very well, and do it across their entire life cycle and keep them out of nursing homes. So we've been doing that for many years. We have currently about 250 patients that are in that program. We hope to have probably double or triple that over the next year because we're partnering with Presbyterian Villages to do that. And we believe that by managing total costs, that many times you can do more for a patient by helping them have a ramp in their home, a microwave so they can eat properly, build a lot of infrastructure into their lives to help them, including adult daycare, which we provide for all those patients, so that in fact patients can live at home and much lower cost than they would if they end up in the system, so to speak. So I think the innovation that can happen with this project is very important, and because of our health plan, because of this program, large number of dual eligibles, we hope to be very engaged in that process. But I hope what we see is that type of structure, frankly, that encourages the integration, that encourages the partnerships, that doesn't look at it, as just a traditional benefit, that really drives some change in the care of those patients.
Right.
Good morning, Nancy. Roger Myers, Presbyterian Village, Michigan. We appreciate partnering with Henry Ford and the Center for Senior Independence. Would you offer your perspectives on the differences between nonprofit and for-profit healthcare?
Boy. It's an interesting question because I think there's a role for both. There are certainly areas in healthcare that struggle on a nonprofit basis to deliver. I mean, you look at the DMC as an example in this community. They basically didn't have an option in order to meet some of the capital needs that they have. And the scale that for-profits can bring to those organizations can be very helpful. So I'm not a negative for-profit person. But I do think that there's a reason that nonprofit healthcare is in place. And that is healthcare is one of the most important social goods that we can provide. It's an essential service. And truly the traditional economic models don't always work for healthcare organizations. Depending on where you are, your location, the poverty that exists, there's a reason why you're trying to do things for reasons other than just the economics. You need to provide care. And I think when we look at our country today, there's a tremendous move afoot to try to get rid of tax-exempt organizations because communities need the tax money. But if we do that, we are going to completely disrupt the ability to provide care in certain locations. So I think much like education, much like churches, there are reasons why tax-exempt nonprofit status was put in place. Now, I think for those of us who have it, we have to demonstrate that we've earned it, that we deserve it, that we are truly community-minded, that we make decisions for reasons other than just the economics, and that we drive, the appropriate results. So, the notion right now at the national level is that hospitals need to demonstrate community benefit. And you do that in a lot of ways. It's charity care, it's community outreach and programs, it's doing the right thing for the people that you serve and basically demonstrating that. So, my hope is that we continue to have some balance of probably both for-profit and not-for-profit, and that we drive the right kind of decisions for the communities that we serve.
Question here.
Good morning. My name is Nadia Shuaito from the College of Management. My question to you is, how are you responding to the current trend whereby the issue of globalization has impacted healthcare? And, being in Michigan, we all know the impact it has had on the automotive industry, whereby they're outsourcing production. And as you know, the trend now is where patients are not crossing borders and going to other countries to get care because of the costs associated with it in the United States. So whether it's going to Canada to get a simple eye surgery, or going to India to get an organ transplant at 20% of the costs. So how are you guys responding to that?
It's interesting because we also see the other trend. We have a lot of Canadian patients that come over to Henry Ford Hospital for care and seek out specific services that we provide. And we're the backup for some of their heart cases as well. So, and we also get patients literally from around the world for a prostate cancer work that we started at Henry Ford for robotic surgery. So I'm not sure, whether it's a trend or it is, a relatively small portion of the market today that are seeking those services. Not everybody can travel like that. People worry about the follow-up care because, many people have multiple problems, and if you're just going for a procedure and, they're not familiar with the other medical problems that you might have, you can have serious consequences. So I don't know that it's a trend per se, but it is certainly something that is out there. And there are parts of the world that have much lower labor costs than we do. One of the things that does add to the cost of care in this country is we pay our doctors and our nurses more than other countries do. But, they also add to the economic strength of our communities by having those resources. But Henry Ford is actually looking at international opportunities the other way, partnering with organizations around the world. We're very careful about that because we don't want to lose our focus strategically here. This is where we serve, this is our home and the core of what we do. But we do think there are some neat opportunities potentially to innovate, to learn, to collaborate, and we, because of the diversity of our physicians, we frankly have opportunities that come up in the Middle East, in China, and in India that we do pursue. But they're relatively modest compared to the core mission that we have.
And we have one final question.
Hi, I'm Kim Hodge with the Michigan Alliance of Time Banks, and I wondered if you're aware of the concept of community skill exchanges, which is an alternative currency. There is a time bank in Lehigh Valley in Allentown, which was focused on reducing recidivism in the hospital. There's one in Maine that has over 700 members, over 100 of whom are healthcare providers, so they're providing kind of healthcare in the community. In London, England, working on mental health issues. Is this an innovation that you're aware of and would be interested in learning about and potentially partnering?
I'm not aware of it. I'd be very interested in learning more.
And with that, thank you, Nancy.
Thank you very much.